Hi everybody, I'm Dr. Roney. Welcome to the Cancer Conversation. And those of you who are on consistently, welcome back. I've heard from a lot of you, I've seen many of you downstairs at the center. I'm doing a lot of the oligo scan testing, so I see a lot of the patients from the center side as opposed to the healing side all the time. So I get the chance to intermingle. So it's good to talk to all of you, and I appreciate the feedback. So I think, you always hear me say the Cancer Conversation is always about educating and teaching because there's this movement that we need to create within the healthcare world more towards this integrative approach, right? I know I'm being redundant, you hear me say it week after week, but I think, more and more what we're seeing is just a lack on the conventional side of getting deeper and deeper involved into asking the question of why, right? They do a wonderful job in a lot of areas. So I don't want to discredit or downplay the job that they're doing because it's fantastic when it comes to, that sick care and the reactionary model. But when we're talking about healthcare, right, true healthcare, what we're trying to accomplish is true healthcare. So we want to make sure that we're teaching it constantly. We're creating this movement so people like yourselves that are watching, that are going to have friends and family members that may be going through things that really need this information, right? And then if they have this information, and I know that if you've been on here, you hear me say this a lot, it is a matter of giving yourself the absolute best chance, right? That you have power in giving yourself the best chance, as opposed to just maybe watching and waiting. I think that is critical to this whole process. Having gone through this myself years ago, I wish I had all this knowledge because it would have put my mind at ease and it would have allowed me to take steps that I had more control. I had more power, again, instead of just watching and waiting or hoping and praying. So the wellness part can be that way as well. So the more we can teach on what to do from a wellness standpoint to keep yourself healthy and the level of detail that now takes, as well as if you have, the symptom of cancer, I like to use that word, it's a symptom telling you that there's things wrong in the body that we need to fix. And then if you're looking to prevent reoccurrence, it's the same concept. We want to put a plan together that's very detailed, very step-by-step, that's going to allow you to give yourself the best chance. So basically, you're empowered. You're taking control over it in a diagnosis that a lot of times they leave you believing you don't have control. And so we need to make sure that we're teaching this day in and day out. We're pushing this narrative. We're pushing the information, having the right people on so you get better educated. So if you do have yourself going through it, family, friends, acquaintances, you can at least share the data. And I think that's a wonderful thing to do. So I appreciate you being on. I appreciate the feedback that I get a lot. It really makes me feel like at the end of the day, I'm making a difference. And I can't thank you enough for that. So anyway, and I want to give kudos for you going outside of the box and looking at all these different ways that you can help yourself and your fellow human beings and mankind. So kudos. Okay, so what I'll do, I'll introduce the topic tonight. So we're gonna have Trish Flannery, who is our F.N.P, nurse practitioner, who also is very integral in the low dose or fractionated chemo department. We're gonna go through that process tonight because I think what I wanted to have happen, if you will, from an education standpoint, Dr. Gama, who's coming, I introduced her last time. She's coming, she's gonna start March 26th. She's one of the best integrative oncology doctors out there right now. Very, very high level, was a pathologist before she started down this road of integrative oncology, has been trained by some of the best fractionated chemo or low dose chemo doctors out there. And we're extremely happy to have her. Trish has been mentored by some of her mentors. So I wanted to have Trish on so we can go through some of these options that we have, or that are out there, I should say, from a standpoint of, hey, what else can we do to help kill the cancer? So if you if you've been on or if you're new, the 4 pillars is a big part of what I like to articulate, because it's a plan. Part of the 4 pillars, which I'll go over briefly, I know some of you have been on here, you might hit mute at this point, I totally get it. But I will tell you, it's so impactful when I go over this with either a potential new patient or somebody that calls me from, an acquaintance or a friend of a friend, and I review the 4 pillars. Their eyes literally light up because they now know, oh my gosh, this is what I was looking for. This is what I needed. They're reading everything. They have, they're Googling X, Y, and Z. There's 8 million bits of information that they're trying to process. And then we come along and go, hey, step 1 is this, step 2 is this, step 3 is this, step 4 is that. And then we can lay out the details in a very formulated analytical plan to make sure we're dotting I's and crossing T's. I just, the impact it has on people is why I like to keep reviewing it, because if they never come here, but they understand that plan, they are going to do as well as they possibly can in this world. And that's all we want. So within our pillar 2 is, how do we kill the cancer, right? So killing the cancer could be chemo, surgery, radiation. It could be immunotherapy. It could be on the natural side, vitamin C, hyperthermia, things like that. But one of the ways that we like to work on that killing of the cancer is low dose chemo. So I wanted Trish to come up and talk about that. As Dr. Gamma is coming on board, she's going to be integral in that department. So I wanted to just lay out what we're finding, what we're seeing, what I'm seeing as far as when patients are doing low dose chemo, and the understanding that it's still only one part of the entire process. Okay, so what I'll do, let me go in and I'll pull up the slideshow like I always do, and then I'll go through with you just briefly again some of the 4 pillars, because I think it's important to, as we're going through a Q&A, is to always revert back to the 4 pillars, because the questions are always going to be related to how we can go, okay, well, that question relates to pillar number 2 or pillar number 3. And I feel like if there's a point of reference, it's much easier to understand. So without further ado, let me go through. You see my CV. When Trish gets up here, I'll have her kind of go through her CV as well. But Trish has been mentored over the last couple of years by, one of the better functional and oncology doctors out there, Dr. Devlin. And then Dr. Gama's going to come on and help facilitate that even more. So I felt like Trish would be a really good opportunity to talk about the low dose chemo. All right, so just to give you an idea here, I mention this each week that we do these, or each time we do these, the wellness part of this. So remember, and I use myself as an example, what I've learned over the last few years, and there's many reasons for this over the last few years, but we're seeing things just escalate. I'll just say that, whether it's autoimmune conditions seem to be escalated and or worse, or they use the term turbo cancers, just things are different now. The best way I could put it. So, and you probably heard me say this last week and the time before that, we're trying to do a more of a push towards wellness this year, and making sure that patients can come in before they get sick and determine if there are things going on that will make them sick, if that makes sense, right? So this prevention plan, and it doesn't mean you have to do this specific plan. This is just something that we put together. If somebody called and said, give me everything, this is what we would do. So to give you an idea, we want to do a lot of the testing. So this goes into pillar 1. So for pillar 1, for our 4-pillar approach, is the testing, right? So number 1, you can't fix what you don't find. So we have to start looking at different layers and levels to be able to identify things. So we do a lot of energy type of testing. What I mean by that is when we're testing on an energetic level, it picks up things much faster than, say, blood, saliva, or urine will. So energy type of testing, like your oligo scan is more light, but biomeridian, 3D body scan, your F.N.P, Firefly, your MEAD testing, they're all using energy. And the idea is, again, energy's got to pick up deviations from normal quicker than blood, urine, and saliva. So that's the most sensitive type of testing, okay? Then you get into blood, urine, and saliva and knowing what to test within those three. And then we do scans. So it goes from very sensitive, less sensitive, to least sensitive. But we need them all. So there is not one test at all, or one treatment for that matter, which I'll get to, that is complete. There's no silver bullet. So we want to look at this as thoroughly as we can. So as we started to get these tests in and be able to expand even our circulating tumor cell testing, which I'll talk about in a second, I now feel really, really comfortable that when I tell a patient, hey, do these things, we're going to get enough data back that we're going to be able to figure out what the heck's going on in their body and what they need to fix. And that way, if we do it that way, if they're a wellness patient, if we do it that way, we're obviously going to be able to prevent as best we can disease from happening, right? And it all gets back to the cell. If the cell is healing, and this is big, if it's healing faster than it breaks down, that's health, okay? But if it's breaking down faster than it could heal, that's disease. So then we have to go, okay, if that's the end byproduct, what causes that? Well, you go up the lineage of events, if you will. It's going to be oxidative stress, right? And that's those free radicals, those atoms that lose paired electrons, that then damage the cell, okay? So the cell damage is oxidative stress. What creates a lot of oxidative stress is inflammation, okay? So those inflammatory proteins, cytokines, things like that are going to create a lot of the oxidative stress. Not the only thing, but it's a biggie. So over here on this side, I like to put it as for looking at a flow chart, we have to look at the gasolines, the propanes, the diesel fuels that are being dumped on the fire. So if we do that, if we're looking at the cell and cleaning up the cell, and we're looking at the oxidative stress that damaged the cell, and we work up from there, we're going to be able to start making progress, whether or not it's from a wellness standpoint, or we need to clean you up with an active chronic disease. Either way, it's the same formula, right? So this wellness plan, if you were a preventative plan, is getting the testing, both energetically, blood, urine, saliva, and scans if need be. So we use all three of those, and then we create very specific plans based on what we find. So again, the biggest thing I could tell you is you can't fix what you don't find. So the investment, right, and I use that term, the investment would be for sure in the testing, okay? So that's what this shows you. And then there's modalities and treatments that we would use to be able to fix what we find. That's your wellness plan, but that's also, if you have active chronic disease, that's your plan too. We need to find things that are causing the oxidative stress and the damage. So that's my spiel on your preventative part. But nowadays, I would definitely be investing, whether it's here or somewhere else, I would personally be investing in that preventative type of concept based on what we've seen over the last few years, for sure. So, all right. Trish is coming on board here. Hello, Trish.
Hello, Dr. Roney.
Good to see you.
Good to see you.
All right, so Trish was downstairs working hard, so she's buzzing in.
Hi, everybody. Thanks for joining us tonight.
Yeah. So again, I gave him a little,
Spiel.
tidbit. Yeah, a little bit on. But so what I'll do, I'll kind of go back. I'll let you review your CV.
Sure.
And then we'll kind of go from there. We'll take it,
Great.
one step at a time. So Trish Flannery, right? Phenomenal. If you've been here, she's like all in. And what I mean by that is she probably gives some of the most, I think, energy and effort of anybody here, to the point we actually had to kind of say, hey, you're probably doing a little too much.
Yeah,
Believe it or not,
yeah,
right? Believe it or not. So, but that just shows the heart that she has and the passion for what she does. So if you know her, you know that. But anyway, I'll let you.
Thanks, Doc. Yeah. So I'm a family nurse practitioner. I'm here at the Cancer Center for Healing for almost 2 years now. And basically, I am in the fractionated chemotherapy department. Prior to this, I was an ER nurse in the city of Chicago at Northwestern Hospital for 18 years. So kind of came here and got thrown into it and just had great teachers with all my docs here and practitioners. And it's just been a great experience. And like Dr. Roney said, I love my patients and I pretty much do anything for them.
Yeah, you do. She does. She does. Outside of the hours, inside of the hours. So, for protection, we had to initially, believe it, and I say this in the most loving way, we had to say, hey, 10 o'clock at night, you might want to shut your phone off, because you were answering anybody and everybody, because that's who you are. So I think that speaks volumes. And I think, here, one of the big things that we've tried to do with everybody that we've brought aboard is they have to have the empathy and the compassion and the passion first. The X's and O's, I know they're important, don't get me wrong, so I don't want to downplay that.
Right.
But we don't want, necessarily people just coming punching a clock. We need the people that are going to be able to put the shoe on the other foot, understand what you're going through, and really understand it. Not just say, but really be empathetic and compassionate to what you're going through, the psychology that you're going, the fear, the anxiety. And then to see that and then empathize with it, I think that's what we've worked really hard to do. And again, I don't want to be patronistic, but I think that's what you bring to the table. So
thank you.
I think
and all
it's
the doctors
huge,
here,
huge
as well
factor.
as you, Doc Roney.
Huge factor.
Very
So,
grateful.
so we're definitely happy to have Trish here tonight. We're going to go through some fractionated chemo. I explained a bit why with Dr. Gama coming on board. A huge addition, addition, an asset to the results.
Yes.
And that's the bottom line. We're always trying to figure out what other test can help us get a result, or other modality, or what doctor can fill in some blanks here. And that's what I feel like we've done a really good job as well. And Gama is I think some of the icing on the cake.
Yes.
Personally. Devlin was huge too,
yes.
and I love him, and he was a phenomenal doctor. It just timing and his workload outside of here, it was having a hard time coexisting, I guess.
Yeah.
Best way I could put it. But Gama's going to be here full time, and I was telling him a little bit of her CV too. Yeah. So that's going to be a good union.
It will be.
It'll be
Looking
a good
forward
union.
to
So
her being here. Yes.
we're very excited. And then I was going over a little bit of, when we talk about the 4 pillars.
Right.
So I'll put those up. So that way, if you haven't been on, at least you know where we're coming from when we go through these questions, and we can relate when Trish talks about the low dose chemo and how it's done. I want to make sure you're able to see how that fits into the big picture of a plan. Because it's really it could be 1/10, 1/20th of the plan. It's an important part of it, but it's one part that can be layered with many other parts to be able to get the best results. Is that fair?
Fair.
So let me just do a quick overview. So the first pillar is going to be testing, right? So we'll do not only the tests that conventional will do, whether it's scans, MRIs, CAT scans, things like that, even the blood work, tumor markers, etc. But we want to get into the circulating tumor cell DNA. We want to get into things like nagalase and PHI and D-dimers. And these are specific markers that really might not mean a lot as a standalone. But when you start layering and putting together 7, 9, 10 different markers, now, as I explain it, now we start with this blank canvas. And as these markers come back, we start to paint a picture. So is that fair?
It's fair, and we get more data, we have more research with it, we just can really tackle their disease process and surveillance them closer with that.
Yeah, and that's so using all that data to our advantage, again, paints the picture, and then we get detailed. And I'll give a quick example like nagalase. You probably heard me say this a million times, but I think this is great. Nagalase is secreted by the cancer cells. And it basically is a defense mechanism. So it blocks the immune system from basically attacking the cancer cell. Well, if we find that high, not only does it help you now, because we can give you things to lower nagalase to give your immune system a better chance, but now it's another surveillance tool.
Correct.
Right? So if we see, these 7 to 10 different markers that we're looking at, or we're doing Pronuvo MRIs now, or we're doing Gallery testing, or what have you, now all of a sudden, if there's something going on, we have no doubt or fear that we won't be able to identify it because we have so many things. Now think about the difference there as, hey, we're just going to do a scan in 6 months.
No, can't do that.
Not anymore.
No.
It's just, it's almost
tight surveillance.
Tight surveillance. So again, I feel great about that, even personally, that if once a year I do all these tests and they come back negative, I feel pretty good. Whereas before, I told the story, when I had melanoma before, years ago, I had nothing other than put more sunscreen on, right? Like, and I'm like, there's got to be more. I always knew there was more. I just didn't have this plan. This plan would have put my mind psychologically at so much more ease, right? And now, actively, we're putting these things into play. I'm more comfortable. Even if something comes up now, which is why I like to go over the 4 pillars, I don't worry about it anymore because I know I have multiple tools in the toolbox that could be layered to be able to get the best outcomes. So the testing is a big part of it. The second part of the testing is going to be your cause testing. So that's where the energy work I was talking about comes in, the blood, urine, and saliva comes in, and then of course the scans. But if we use all those to our advantage, both cancer and cause, we're going to be able to find things, and then we're going to be able to fix things, right? So that goes back to that concept of there's gasoline being poured on your fire. The inflammatory fire causes a ton of oxidative stress, which damages the cell.
Correct.
At the end of the day, we're going to talk about how to clean up the cell, but we certainly have to get rid of the inflammatory, gasoline, if you will. That's a big deal. Okay, so pillar 2 is starving it and killing the cancer. Starving is going to be your Dr. Seafried, who we had on about a couple months ago, and he is talking about the metabolic effect on cancer and the part, right? So that is going to be your glucose and glutamine. So cancer cells ferment, and they use the fermentation process of glucose and glutamine. So Seafried's work, his research over the last decade or more, tells you, hey, if we get a GK index below 2 and we pulse the glutamine, his research shows that's significant in starving the cancer. Okay. Then if we use repurposed medication, your metformins, your fen and menbendazoles, your antiparasitic, some statin meds, there's a lot of them. The point I'll make is those meds, and I'm simplifying it, help block some of the pathways that feed cancer.
Correct.
So if we're doing a starve phase with the glucose and glutamine and the repurposed medications, we've got that part handled.
Right.
Again, another layer to the whole process. Then if you look at the kill phase, that's chemo, surgery, radiation, low dose chemo, immunotherapies. Again, it could be hyperthermia. It could be vitamin C IV combined with artesunate. It could be a bunch of different integrative type of cytotoxic modalities that could kill the cancer cells. What I tell people, and I think you would attest to this, is because people come here because they really want natural.
Correct.
As much as
Holistic,
they can.
Yes.
And we really work hard to try to give them that. The tough part is, depending on the diagnosis, the way I like to put it is, sometimes these are BBs, bullets, and cannonballs, and you might need an atomic bomb.
Correct.
Okay? So I also say, and Trish and I have talked about this, we're conservative, but we're not naive.
Right.
So we have to look at all that testing that we talked about, paint the picture on the canvas, and then say, you know what? Because it says this, we think you need that. Fair?
Yes.
Very objective.
Yes.
Very objective. So even if you came here for natural care and we saw all this, our job is to treat you like a family member and tell you exactly what we would do based on you being our best friend, wife, husband, whatever it might be. It doesn't mean you have to do it,
right? But
it may be something that we need to tell you, because the BBs and the bullets and the cannonballs for what you have might not be enough.
Right.
Okay? And that'll tie us into the fractionated chemo part, which give me one more minute and I'll talk about pillar 3, which is, what are the hallmarks of cancer? Weakened immune system is one. So we definitely want to boost your immune system the day you walk in the door, or would recommend that to you out in, at home if you needed to do it. The second part is low oxygen, right? We know the cell goes from aerobic to anaerobic respiration, which then in turn causes high acidity, okay? Because when you're hypoxic or low oxygen, we're going to be acidic. Number 4, we get low voltage. That's from Dr. Tennant's work. So that's another thing that we want to address. At home, you can ground. Here we use the biocharger, biomodulator. And then finally, we use the oligoscan to look in the cell to see where your trace mineral levels are and if heavy metals are getting in the way. So if we do that, we're starting to change the cell around and the environment that is really conducive to cancer growth. Now we're trying to change it to where it's not. Fair?
Yep.
And then finally, your causes. We already talked about those. Your pathogens like bacteria, viral loads, parasites, candida or fungal loads from mycotoxins, heavy metals, non-metal toxins, etc. They're all big that we want to look at. We also want to look at your stress and your hormones. We want to look at thyroid. We want to look at your anemia levels or your iron levels. We want to look at your blood sugar imbalances if they're there. We want to look at your diet, your exercise, your sleep patterns, your electromagnetic field exposure. All of it, unfortunately, matters. But that's the part where if you're looking at, the pillars, okay, and we isolate pillar number 2 and say you did either low dose chemo or you did high dose chemo or dense dose, it's still only one part of this plan. And in order to make sure that we're able to give you the best chance to heal and to get better, it's implementing as much as you can of those 4 pillars. Okay?
Correct.
So that's my, I know it's long-winded, I know, I get it. But I think that will help if you're new to this. I think it will help because a lot of the questions will be able to revert back to the 4 pillars. Okay? Anything to add to that, Trish?
Number 2 pillar, right? With the fractionated chemo and
exactly
the dose dense chemo.
That's it. So I'll let Trish talk a little bit about, her specialty is the low dose chemo, and then kind of what happens, how it works, etc. And then we'll get into the Q&A.
Okay, great. Yeah.
So take over.
All right, so the low dose chemo is basically chemotherapy that we give with a biomodulator or biological response modifier, which is insulin. Cancer cells have 10 to 16 times more receptor sites on the receptors for insulin, and they have an IGF-1 receptor 2, insulin growth factor 1 receptor, which kind of wakes up the cells that are sleeping, the cancer cells that are sleeping and lying dormant. We like to shake those up and wake them up. And the reason we do that is we will give you insulin and get your sugar level down between 40 and 60 before we start giving you the chemotherapy. And you want to picture your body like there's little Pac-Mans inside that are ready to gobble up whatever's coming next because of these insulin receptors. It's the chemotherapy first at the table, like that's what they're going to gobble into those cancer cells. Like I said, there's 10 to 16 different receptor sites. So preferentially, that's where the chemo goes. It doesn't normally, it doesn't really go to the healthy tissue cells. It'll predominantly go to the cancer cells. And for that reason, we usually don't get a lot of the side effects that they do with dose-dense traditional chemo. I don't see as much, I don't get a lot of nausea, vomiting, hair loss,
neuropathy.
I get some of it, I have to be honest, but not as much. I know the research shows that maybe it's like 50% less. And what I'm experiencing after doing this for 2 years is, I'd say 70 to 80, if not more, reduction in side effects.
I agree with that. Yeah, I don't see a ton. So people ask me, and I go, I can only give you what my eyeballs tell me.
Right.
And I definitely see a much better tolerance for sure.
Right. Yeah. So the mechanism of action is different with the fractionated chemo. As I said, we work on the biomodulator, the biological modifier. The insulin, and regular chemo goes everywhere in the body basically, and that's why so many people get the negative side effects. A lot of people come to me and they'll be like, I can't handle dose dense traditional chemo, and we'll be like, okay, well, we'll try this. It's a different mechanism of action, and a lot of people just do very well. And
so your insulin, right? Blood sugar down, therapeutic range, you try to get it
40 to 60, usually 40 to 50 is like that sweet spot.
So during the process, there's nurses in there, at least one that's checking blood sugar consistently, making sure that it gets into that range. Once it's in that range, then the chemo is infused, right? And again, the idea, just to keep it as simple as possible, it's kind of like a vacuum effect.
Yeah.
Right? So the chemo's in there, the blood sugar's down, all those receptors are pretty much starving, if you will.
Ready, yeah.
And they're basically sucking that chemo in, where those other healthy cells aren't as affected because of that biological modifier, which is the insulin.
Right.
Okay, so with that, there's a lot of questions that I get, so I'll give you some of the ones. Now, obviously, it's less of the dose. So it could be 10%, 20% of the normal dose.
Yeah, I'll usually go up to 25%.
If need be,
If need be, yeah. If we pivot, if we check cancer markers every 6 weeks usually, and I'll do PET CTs usually 90 to 120 days, and depending on how many fractionated chemotherapies we decide, do we need to pivot, don't we, do we stay at the 10%, do we go up to 15%, do we change the chemotherapy agents at this point? So it's kind of like a balancing act the whole time. We're surveillancing you very tight, and we're looking at to make changes where we need to make pivots when we really need to.
And then even before, I think this is important too, is when we're looking at what chemo agents to use, we're trying to use the data or the testing to our advantage there as well.
Correct.
So, I don't want to use, well, I will use the word. Sometimes I feel like it's just opinion. Could be more cookie cutter. Oh, you have this, we're going to use this because that's what we always use. Mm-hmm. What we're trying to do is, yes, follow that as well, but then dial it in even better to where if we're using the chemo agents, like the garden can help us with dialing in a little bit better. So the sensitivity is towards those cells based on that person's DNA.
Right. And then we always use standard of care NCCN guidelines to guide us with those chemo agents. But yes, like Dr. Roney said, we use we'll look at the RGCC, we'll look at the Dietary, we'll look at some of the NGS, which is the next generation sequencing that he mentioned, like Guardant, Cell Search. What else do we have? We have a few.
Effulgence,
Signatera's. Yeah, we just follow a lot of data just to get more information.
Yeah, I think it's, again, just, anybody that comes to us or just any type of program like this, you're trying to make it as individualized as humanly possible.
Correct.
It's still not an 100% exact science. There's no 100% guarantees to this. All we're doing is taking the information and trying to dial it in that much more, because again, the results are going to be that much better.
Correct.
So it's using all that, and then once we get dialed in, then we use the biological modifier and lower the insulin, so the chemo has a better chance of targeting the cancer cells as opposed to damaging all the cells
in the body. Yeah.
And that's where the lower amount, in addition to using a less dense chemo amount, we're using a more targeted approach there. Okay, fair? That's good. Yeah, I love it. I think it's great. Okay, so you went over the receptors. We know there's a lot more GLUT4s. We know there's, like you said, kind of like the Trojan horse.
Yeah.
It's sucking them up, and leaving the healthy cells alone. All right, so because I think we'll get this question is, when is this appropriate?
Yeah, so fractionated chemotherapy, anybody who has, cancer can basically, look into fractionated chemotherapy. A lot of the blood cancers, I'll be honest with you, like your leukemias and your lymphomas, they usually tend to do better with dose dense. So we usually will not start with fractionated chemo. However, I've had a couple of patients who have been getting dose dense and just couldn't tolerate it. So of course, I'll work with them. And we've had good results with it. It's just, we usually tend to send them out to dose dense because the research is really in the blood cancers that they do better with dose dense.
Yeah.
But other, solid tumors, any other tumors do great with fractionated chemo. I have patients with all different types of cancers.
And what you'll see with some of the questions that we get is, okay, if we had to send somebody out because we're looking out for their best interest, right, based on the research, based on our experience, is then, okay, do these things, right, do the kill phase, and then make sure we're supporting the body with all these other modalities. Your immune boosting is going to be a critical element.
Very much so.
When you're going through, whether it's dense dose or low dose. Preparing for surgery, getting the immune system, getting the body ready, using the IVs. Make sure you're using oxygen therapy, whether it's ozone or hyperbaric or CVAC. Remember, hallmark of cancer is low oxygen. The cells become low oxygen. So we want to be able to do things, grounding and such, that are going to be able to get the cell stronger and healthier and change that environment around. But again, probably if you're going through chemo, your immune boosting and your oxygen, in my opinion, are kind of like they're big.
Huge.
They're big.
Huge.
Making sure you're getting your electrolytes, making sure you're getting your fluids. Again, ascites and different things could, we might have to pull back on some things with something like that specifically. But in general, you still want to support with these other pillars and make sure we're cleaning up what potentially could be causing it as best we can through that process too. So even if you had to, because I know I get the look at disappointment, because I work with patients usually within a day or two being here, and I always ask what their goal is. And a lot of people come here and their goal is to avoid those things. And it's a tough conversation, but it's a real one. And we want to be as transparent as possible. And I always tell the story, gang, that if you have to go, with the bomb or the atomic bomb, like a low dose or a dense dose chemo, I've watched people do really, really well by the numbers, right? Meaning a lot of people when they're doing these other things with it. I personally tell everybody I wouldn't do these chemos or surgery or anything alone. I would always pair it synergistically with all these other modalities. Again, just to keep my body as strong as I possibly could, but also to start healing throughout the process. So I think that's critical because I know some of you might be like, I don't want to do that. Well, again, benefit risk. Sometimes what we're seeing in that canvas with all the data, we have to give you our best advice, even though we know you don't want to hear it sometimes. But I tell everybody that will listen, when I first came here, I was very opposed, but now I would absolutely consider all of it because of what I see the benefit of doing this. When I say this, whether it's low dose or conventional, with all this. That's when the win happens. When my dad, per se, years ago went through chemo, I think that got him before the cancer, right? And it was a rough go. And I tell patients that. So when I came here, I was pretty opposed. I made a complete 180 to where I would absolutely consider it as long as I had all these things in my, in my back pocket that I was utilizing together. So I think that's worth just my opinion.
Right.
But would you
I
agree, right?
Totally.
And it's just based on what we see every day, to be honest with you, gang. Okay, so let's get into some questions here. So it brings up that point. Is there anyone who should not consider low-dose chemotherapy?
Yeah, my feeling is every cancer patient should consider it because it's based on the mechanism of action, like I already, explained how the insulin works. Patient, like I said earlier, also the blood cancers, we usually do go dose dense with those, but there are some, heavy stage 4s that come to us that really through traditional have been told, go get your affairs in order. There's nothing we can do. We will take on those patients. We will fight with them as best we can. But some of those we have to be honest and say, you know what, you need more. You need, we got to give you the big guns right now. You've got to go dose dense. And then you can always come back, right? So they can get treatments, until they can't tolerate it or until, they are in a position where they can come back to us and then get the dose or the fractionated chemotherapy.
Yeah, good point. And I'll bring up this too, and this is, again, eyeball test. What I've seen is that no matter if they're doing dense dose or low dose, right? The layering is significant. Fair?
Yes.
Meaning, especially low dose, I would say. I think I've seen it work really, really well. I've seen it work really well with hyperthermia, for example. Combination of hyperthermia and high dose vitamin C, combination of those three plus. Even immunotherapy, intratumoral immunotherapy potentially could be something that could be layered. So the point that I'll make is I love the fact that now, and Devlin helped a lot with this, we have affiliate doctors, we have affiliate clinics, we have affiliate resources that if we said, hey, this person's got a lot going on, they want to do low dose chemo, we'll do low dose chemo, but then we'll layer it with a bunch of these other modalities. That's, to me, where I go, that's a key.
Right.
That's a win. I see wins more and more when there's layering. Again, we may not need it all the time, depending on a diagnosis, depending on staging, things like that. But I do believe, from what I've seen, eyeball test, is that personally, I would definitely do a lot of layering.
Right.
Would
And
you?
those patients usually do the best.
Kind of like you come out with guns blazing.
Yeah.
And you're firing bullets and BBs and cannonballs and grenades and bombs.
Right.
And sometimes that's necessary. And like I said, between the testing that we do, the modalities that we have, and then the affiliate clinics that we're also able to refer to, that's what I feel really
Right.
good about these days.
Right.
You know, it's just a big difference than when I started taking over healing 2 or 3 years ago.
Right.
I felt good, but now I feel great.
Now you feel great because it's all those layers, like
It's
you
all-
said.
it's all
like,
those
For
layers.
instance, you mentioned hyperthermia, and we have Dr. Pinzone, who does the hyperthermia, who is going to be opening up another center here close to us, I think within 5 miles.
Yeah, and so I'm going to ask a question on camera because I thought it was mid-February. Is it open
It
yet?
changed. No, not
Okay,
yet.
okay.
He really won't give us a specific date, but I know he has the property and they're working on it, whether it be electrical or whatever.
Okay.
But basically, what his therapy is he'll use ultrasound. He uses ultrasound to get into the tumor, wherever the tumor is, and he'll penetrate through the skin. He'll go 8 to 10 centimeters into the body to get to a tumor. And what he does is he heats it, that cancer bed, that tumor bed, to like 109 degrees Fahrenheit, where another layer that synergistically works and just blasts the cancer. So we've had a lot of good results with his treatment also. So
Yep, the
we're excited
layering.
about him coming.
Yeah, exactly. So yeah, that's a big one that I've seen work well. Hyperthermia, if you've ever done research on it, it's fantastic, the research. We have it here, so we'll use it on smaller areas,
Right.
prostate, we might use it on breast, we'll
Breast.
use it on just areas that we know we can get to. If there's more involved and a lot deeper, then we'll send to Pizzone. And to your point, that's the beauty of it. We may not be able to do it all here, but we will find you where it can be done to where collectively you're winning.
Right.
That's the key. That's what I love. It's not just, hey, we're going to hold on and do what we can and that's it. We've created these affiliate relationships
Right.
that we're going to be able to, if you need it, we're going to say, look, this is a really good idea. It's not here, but we want to refer you to this place and this is why. And it creates another layer.
Exactly.
That's the key. So again,
Here's our next
yeah.
question over
What you
here.
got?
So, have you used treatment with LDN, which is low dose naltrexone, for stage 4 thyroid cancer, which is probably metastasized to the lungs and is invading the esophagus? So basically, we do use LDN. I give it to majority, almost all my cancer patients are on LDN, regardless of their stage or their type of cancer. It is contraindicated if people are on like narcotics because it works off the same receptor.
Yes.
Basically, it takes away
It does.
that pain.
It'll be antagonistic.
Right. So, low dose naltrexone, it shows evidence suggests that endorphins, upon binding to the cancer cells, trigger this apoptosis, along with stimulating the natural killer cells and the helper T cells. LDN is an immunomodulator. And it's good for neuropathy. It's good if the patient has inflammation, which we
Autoimmune.
check. Autoimmune diseases. With inflammatory markers, we like to check with our CRP and our SED rate, just to see, if they would be a candidate. But most of my patients, honestly, are on it. It's not hard to get LDN.
No, and it's they use that there's a term or a growth factor. It's an opioid growth factor that's in cancer cells, and LDN is an antagonist to the opioid growth factor. So the opioid growth factor is responsible a lot of times for cell proliferation. So when you give LDN, it blocks that opioid growth factor and then it slows the proliferation rate. Really good, and then we've used it for years. I've been in the autoimmune world even before I came here for years. LDN was something that I would make sure that the patients were on as I'm working through trying to figure out why their immune system is so dysregulated. So you use LDN, you could use, not you all, but like glutathione and vitamin D, and you could use a lot of natural things to kind of calm things down. And then again, if you get rid of the fuels to the fire, clean up their gut, clean up their diet, clean up leaky gut, parasites, infections, toxins, chemicals, all of a sudden the LDN becomes less necessary because we've actually calmed the mechanism down. with cancer, that cell proliferation is a big deal. Now, again, it's one part of it. So I wanted to mention this with LDN, and I'll parallel it. Had a patient that I spoke to yesterday. I'll do potential new patient consults. And basically, I just want to share with them the 4 pillars. Whether they ever come here or not, it's not my objective. I just want to get them the word out because I think they need it and they don't get it otherwise, right? Well, the patient their main question was about something called methylene blue.
Right.
And they also asked about LDN, but methylene blue is the main question. So what they do, because they're reading and they're searching and they're like, hey, maybe this is my missing piece. So I explain what methylene blue does, just like I just explained what LDN does. But remember, that's just could be 1/50th of what we need to do in order to knock this thing out. So some look at it like, wow, I've read this, I could do this, and that's my silver bullet.
Right.
Unfortunately, in this world, and I just wanted to mention, unfortunately, it just doesn't exist, right? If it ever worked that way, it would be the extreme exception, not the rule. So I want you to look and view things like that as one piece of the bigger picture. That's fair, right?
Yep, fair.
So, but it is a part of it that I think is pretty exciting. So I just wanted to mention that.
Thanks,
all right,
Doc.
what you got?
Next question. What are the simplest and cheapest things to do or supplements to take for pancreatic cancer if I do not have money to pay for a functional doctor? Repurposed medications. I don't know if you guys are aware, but Jane McClellan in her book, How to Starve Cancer, is an excellent resource. Repurposed medications help to mitigate the side effects and deal with the disease head on. These medications help to create this micro tumor environment that is inhospitable to the tumors. So by shifting some things that go on between how the tumor metabolizes the substrate, how it can kill the cancer stem cells and potentially stop the spread of disease. It kills off pathways to cancer. These different repurposed medications, metformin for one,
biggie for
is known, and is known to kill cancer stem cells. Very important. If we are able to put the patient on it, obviously we have to look at their hemoglobin A1C, which is their trend of what their sugar levels are, what the average is over 3 months. We don't want to put them on it obviously if it's too low, right, and give them some of those low sugar effects. But majority of my patients are on it. I would consider it my number one. And like Dr. Roney mentioned earlier, there's the statin drugs. There's doxycycline, which is an antibiotic that we cycle patients on and off. There's the anti-health, which are the anti-worm, anti-parasitics, the mebendazole, albendazoles. There's also ivermectin, which kills off another pathway to cancer. So it's just very, very interesting how there's so many, cancer's so conniving and it's got all these different avenues that it takes. And we just want to stop it. And our way of doing that, I think there's over 140, I think, repurposed medications literally that patients can take. But we have 4 of our really big go-tos and then other ones that we like to use.
Yeah, and I'll add to that. I think especially for pancreatic, I think using the Siegfried's work as far as starving it, where you're really pushing down on the glucose, for sure. So those cells that basically secrete insulin, the islets of Langerhans, right? Mm-hmm. They get affected with pancreatic cancer. So if you're not stimulating them as much, if you're able to decrease insulin that's secreted by those, that pancreas is going to work less hard.
Right.
And that's a biggie. So going back to pillar 2, the starve phase, you're looking at doing the repurposed meds, hopefully, potentially, that can block some of the pathways. Metformin's probably high on that list.
Very high, yeah.
And then if you can press on the glucose and pulse the glutamine using Siegfried's work, now you're talking about having a pretty good impact with, like you said, not having maybe the finances to do the functional work.
Right.
Those are probably the 2 main things that I would work on. And if you could check, I was reading something not too long ago about toxins as it relates to, say, the gallbladder and or the pancreas. Mm-hmm. And I think those small channels get blocked based on what this research was showing with those toxins. So if you could do some light detoxing, or can get that tested, get toxins and heavy metals tested, that might not be a bad idea either. Going through maybe a 14-day detox. I don't want to be super specific, but just some of those things that can give you, I think, the most bang for your buck, if you will.
Right.
So,
right.
Yeah.
Which we're doing a lot more of right now, is checking the detox pathways, because a lot of our patients aren't methylating, and we're finding that out now and doing the testing, and it's like, what does that do? That means that everything, the chemo that I'm giving him, or the medications they're taking, the supplements, everything's like doubling, tripling. Like, we've got to work on this. This is foundational. Yeah. So we're doing a lot of work right now with our patients, and they're feeling so much better. They don't, they would come to me, they're like, there's something wrong. There's just, I just don't have the energy. I just feel so sick, and I'll be like, okay, let's figure this out. And a lot of the times it's because they're not methylating. They have, mutations in their MTHFR or their COMT, their
MTTR,
yes,
your DALs, the GAOs, they're I'm glad you mentioned that, because that is super significant. So probably the most upstream that we could get as far as testing upstream in somebody's health is going to be their what they call SNPs, their epigenetic factors. Real quick, we're born with gene mutations. We're all born with them. It's not a major factor unless those gene mutations start to express. Lifestyle, Ben Lynch is really, really good at this, has a great book if you ever want to read about what they call epigenetics. That book really, really outlines it well. But the point I'll make is, we have gene mutations that start expressing. Once they express, it can affect our hormone balance, it can affect the way we detox, it can affect the way we control inflammation, our brain, our mood, our cardiovascular system. It all matters. Trish mentioned methylation and MTHFR gene. That's a biggie. So if you're somebody, we get this a lot. I'm sensitive to a lot of things. I can only take a little bit of this or a little bit of that, or whatever it might be. They're the ones that chemo actually affects them even worse, because they're not able to get rid of it.
Right.
They're not able to methylate or detox. So I think it's a great idea, and I think you do this now, and I think Dr. Gama is big on this too.
Yes, she is.
Looking at these detox pathways, looking at these epigenetic factors first, like day one. So then if we need to work on those, and there's some simple remedies sometimes. It could be just methylfolate and methylcobalamin.
Exactly.
That really helps. So it could be that simple that starts to get these pathways working, and then all of a sudden you're like, oh, I feel so much better. Not only is the exposure to, say, heavy metals and toxins no longer building up, but if you're going to do fractionated chemo, especially here, or chemo, we really should, as a first step, look at that. I'm glad you brought that up, because I think it's imperative, and you hear it everywhere now.
Right.
So a lot of the longevity people that I follow, they're all over the methylation gene.
Yeah.
So I think it's a great point. So taking that even outside of here, if you're not here or you can't come here, that's probably high on the list as far as things that get looked at, whether you're a wellness patient preventing cancer, or you have active cancer, or you're trying to prevent reoccurrence. I think the methylation is a biggie.
Yeah, and I just wanted to mention also, because a lot of my patients are like, but we were told B vitamins, it's a cofactor to cancer, and yes, it can be if it's in a range above what it should be. And that's why we surveillance your B vitamins so closely. I run them like every 6 weeks on my patients, just to make sure they stay within that range, especially if I'm giving them a methylfolate or any B vitamin. Correct. So just so you guys know that yes, it does.
We're keeping a close eye.
Yeah, just to make sure it doesn't aid and abet the cancer cells. Yep.
And there's a lot of things, right? Iron, too much iron and too much.
Right, copper, all those things, like they can be cofactors.
Yeah, and we have to be, it's tough because we need enough for proper function.
Correct.
But then when it gets overloaded, then there's evidence to show it can be detrimental. So to Trish's point, she's always looking at making sure that what she's given is being measured as well.
Correct.
So it's great. It's great. It's just another level. All right. What you got? Excellent.
Okay. Can a tumor be surgically removed and not spread the cancer? I just wanted to say, first and foremost, that at the Cancer Center for Healing here, we have pre and post surgical protocols in place where we help to mitigate, because some people, like Dr. Roney said, they have to go for surgery. They don't have another option. So we kind of aid that healing process, right, before and after. Research suggests that having a tumor removed prevents local recurrence also. There is this phenomenon that by taking out the mother tumor, which takes away the potential internal suppression that the mother tumor was making to keep these little satellite lesions, which are throughout your body, whether they were in your lymph nodes or your peripheral tissue or the liver, kept them from growing excessively. So they can be just a small cluster of cells. If you do have a reversal surgery, now your immune system has to focus on getting re-traumatized and pay attention to not getting an infection or sepsis or anything bad to occur while you are healing. A lot of energy goes into the process of healing. But basically, there's this mechanism that is prevalent in any solid tumor where, like I said, these satellite lesions can be suppressed by secretions from the mother tumor. If you do remove that mother tumor and no longer get therapy, those things can grow. And that is why we see recurrence 4, 6, or 8 months later after it was removed. It's because now those sort of unsuppressed satellites are allowed to grow and do their thing. And they're less likely if you keep getting chemotherapy by putting pressure on it, or by getting the repurposed meds, certain supplements that we give you, the therapies that Dr. Roney mentioned, the energy and all that, all those things are trying to suppress the cancer. So it's just an interesting phenomenon.
Yeah, and that's where some of the testing, like your circulating tumor cell DNA, that's important.
Very
right?
important.
We want to look at these numbers. We want to look at your NAGLACE. We want to look at PHI. We want to look at, we don't, again, not just relying on, say, a scan. So we do a surgery. Hey, we got everything. It looks good. No evidence of disease. We'll scan you in 6 months or whatever, right? But if we did circulating tumor cell DNA and checked a lot of these tumor markers, checked the NAGLACE, the PHI, maybe did a full body Prenuvo, who knows? There's a lot of things that can be done, and then if all those came back good,
right,
we've got a pretty good chance to say, hey, that's true, they got everything. But if these things are there, and they potentially could be secreting some things, or right? We want to look at that. And to your point there, the reason that they'll say, hey, we want to do radiation or we want to do chemo is because the tools in the toolbox don't allow that degree of certainty. Does that make sense?
Yeah.
So it's basically they're telling you their truth. They're saying, look, we don't want to mess with this.
Right.
Nowadays we have it seems like younger and younger patients here.
A lot young.
So when that happens, when you see, like I had 31-year-old, 33-year-old, and they're asking, hey, what do you think? And I have to give my opinion. I'm like, look, at your age, with the data that's presented, you probably want to consider, after surgery, these things.
Right.
Or before you did that, let's at least look at the data, and let's use the data to help guide us and make an informed decision.
Right.
But again, when you're young and we have all these years to live and be healthy, it's hard not to do some of the more aggressive things, especially to your point, when we have all these protocols that can offset the downside.
Right.
That's the difference here. So it's not in a bubble where we just do this and you'll deal with the consequences. We're saying do this because the juice is worth the squeeze.
Right.
But yet do all these things so you don't have a downside. You get the win-win.
Right.
That's sometimes some of the things that we're faced with. So I think that was good that you mentioned that, because that could happen, and it does happen. So we need to test it a little further. But then we also may agree that maybe we should do these things. Not that we want to, but it's just being realistic,
right?
And using experience and age and some of the data too. We have patients with breast tumors that have the pathology, and their Ki-67 score is very high.
Right.
And when that's high, even though it might be a small tumor, that means the proliferation rate is high. So if there's less over-sedescent cells, or some of these cells that, or roots, if you will, that Trish is talking about, you're like, ooh, that could, right? So I'm just kind of giving you a little insight on sometimes the thought process that the doctors have to have here to make sure that you're good, even if it agrees sometimes with some of the conventional stuff.
Right.
There's a method to the madness, I guess. So anyway, good.
Okay, next question. Does ivermectin or other antiparasitic drugs take a toll on gut health? So ivermectin, generally, it is tolerated well. I want to say I've had one patient, maybe two, that complained of a little bit of stomach upset that I took off it and, pulsed them back on it later just to make sure that was the culprit. But basically, it may cause some GI effects. It can cause nausea, vomiting, abdominal pain. But like I said, I usually don't see it. How about you, Doc?
No, I really think it's one of the safer meds. When it came out for COVID, we did heavy research on it. It's used in other countries as an anti-malaria, anti-parasitic, and children use it. It's one of the safer meds out there. So I really don't see many issues with it at all.
Okay. If I have been diagnosed with cancer, when is chemo appropriate? There's various factors that come into play, such as your cancer type, your stage, and the individual's overall health. Some types of cancers are more responsive to chemotherapy than others. Stage of cancer, such as if the cancer has advanced beyond a certain stage or it has spread to other parts of the body and metastasized, that all plays into it. There's surgical options like we talked about. There's neoadjuvant, which means giving chemotherapy prior to surgery in an effort to shrink tumors and making them more manageable for surgical removal. Chemotherapy can be used also after surgery, which is known as adjuvant, to eliminate any remaining cancer cells.
Which is what we were just talking about,
In some instances, other treatments such as surgery or radiation therapy are not sufficient on their own. Chemotherapy may be recommended to target cancer cells throughout the body, right? Like I said, those satellite lesions. Overall health and age of the patient plays an important role also, right? Their lab work, white blood cells, red blood cell counts, these are very important factors that we have to constantly be monitoring and looking at prior to giving chemo, even if it is fractionated. But chemo is used to put pressure on circulating tumor cells that are trying to take up residence. They're trying to nest, they're trying to find another home, and that's what the fractionated and chemotherapy traditional dose does. It says no to those satellites. It says you're not going to rest here, you're not going to sleep here, you're not going to, build this home here in another organ in the body, right?
Yep.
So it prevents that from happening.
Yeah, and you some of our most successful cases came in stage 4, a lot of stuff going on, got them to no evidence of disease, yet they're still on some type of regimen of low-dose chemo.
Correct.
And so explain that, like you were saying.
So usually when I have a patient, standard for fractionated chemo, I'll give estimation of 12 treatments. So that's 12 weeks. We give fractionated chemo weekly. We're in dose dense because it pounds the body so much. They're like every 3 weeks or every 6 weeks because the body has to recuperate, not with fractionated chemo. We give it weekly. I'll usually say the first round is going to be for 12 weeks. Now, even if you come into me with no evidence of disease, which I have patients right now who have come here and no evidence of disease, and I give them so much credit because they're proactive and they know about those satellites and they know they don't want them to take up residence elsewhere in their body for metastasis, right? After that, like say I get you to no evidence of disease, then we'll pivot. We do pivots all the time. What I consider no evidence of disease is when I'm checking your cancer tumor marker, your markers, and making sure I check them every 6 weeks, sometimes more frequently. Sometimes I'll go 2 weeks, it depends. Sometimes the patient asks me, Trish, can you do it every month? I'll do it.
Sometimes it's warranted.
And cancer markers can trend up, they can trend down, right? And that's when I make my decision on pivoting, whether or not I have to pivot a patient. But basically, with the pivoting, we might give a different chemo. We might cut down if they are no evidence of disease. I say, okay, now you can come out every 3 weeks. So a lot of our patients live out of state. They will fly in for a couple of days a week. Obviously, best case scenario is they're here, they're getting all the treatments, they're getting their IV therapies, their artesunate, their vitamin C.
Their surveillance.
But some people, they have families, they have kids, they have to get back home. So they'll fly out literally for 3 days. They'll do their chemo one day. They'll do these supportive pushes with a lot of their other IVs the day after chemo, and then other supportive therapies the third day when they fly back, trying to maximize their time here.
And then they're doing as much at home that they can.
Yeah, some of them find centers where they can get their vitamin C and their HBOT, their hyperbaric, different modalities. So it works. It's just figuring out what works for them, basically. And we work with everybody. We do what's best. We're real into patient autonomy here.
Yeah, for sure.
And that's, I think, what makes us so successful and our patients successful, because they know that they can talk and they can be heard, and we'll work with them.
And I had Trish mention that as far as, because that was a new revelation to me. Oh, there are no evidence of disease, but we want to still have them on some type of push, because if they're that young, and a lot of them are younger, right? They're that young, they've had stage 4, you know, again, in the conventional, it's like, oh, no evidence of disease, you're good. It's like, whoa, you know, we and Devlin had said this before. He said, I've been down this road too many times to know that we let them go. 6 months later, it's
an
back.
Inferno, yeah.
Because we didn't probably, whoever, didn't do the surveillance as well or as frequent as needed, and or didn't keep pressing on these cells that even the labs, even if we're getting total cleanliness in the labs, and they're a young patient with some aggressive type of cancer, there's still, I think it's just safety and insurance,
right?
Especially if it's low dose, they're tolerating it well, they're feeling great, they're doing all this other stuff. I'm like, why not?
Yeah, exactly.
Why not? You know, so that made, I was like, wow, that's a very like a novel concept, and we're seeing it work really, really well, and that's experience. That's when I think Devlin came in. You know, his 23 years or whatever. Right. He's like, oh no, I'm going to tell you, experience-wise, we want to keep doing this. I love that. Yeah. I just think, you know, again, between, and I mentioned this earlier, so I don't want to be redundant, but between the surveillance that we do and you know, methodologies like that and affiliate clinics and, you know, the modalities that we have to support, I mean, it's like, okay, I think we're dotting a lot of I's and crossing T's. And I'm pretty hard judge of that, because I know I look at it like, okay, for me, would I be satisfied?
Right.
And I hope that didn't sound arrogant, but it's like, with the knowledge that I have, I go, okay, I think we're doing pretty good.
What it takes,
and we're always looking for the next thing too, which is a great thing too. So that's not, I don't mean pat myself on the back, but I do believe that what we put together and had help with putting together, I feel pretty good about it. Yeah. Do you?
It's a good plan, very much so, And we'll even bring patients out once a quarter if it warrants it, if they've been NED for like, you know, 4 times, you know, every 3 months we get the scans, 90 to 120 days. And if they've gone through 4 of those scans, it's like, okay, we're still putting pressure on it. We're still letting those satellites know they can't rest there.
Exactly.
And they're still doing the repurposed, you know, whatever they can tolerate. They're still, it's a constant putting pressure on the disease. Obviously, you know, we're at a win at 2.5 years out being in NED. And then obviously best case scenario is we want you out 5 years NED, where we can kind of loosen the reins at that point. But it's something we really have to surveillance and stay on, and it's a big commitment. It's a lot of work, but our patients are up for it. They do the work.
No, they do. And again, when they're younger, I see that the younger, we just have to almost go, okay, it's not that even the older one will still do the same thing, but those younger ones, it's like, oh, do we really want to pull back the reins when you're 31 or 33 or 35? You have 2 kids. It's like, oh my gosh, like, you know, if this is what we've seen work, or the experienced doctors have seen work, hey, and they say, hey, I haven't lost anybody in years because I use these principles. It's like, yeah, that's what we're going to do.
Yeah.
So anyway, go ahead.
Okay, so next question. What are the options with full dose or low dose chemo? You have both options, and you need to decide for yourself. Like I said, autonomy. After, you know, we like you to consult with your oncologist, have a consult with us, and then make your decision based on what you feel is best for you, which one resonates with you the best. I'm into the patient autonomy, like I said, like every practitioner here. We work with you according to what resonates with you. We want you to be able to say that you did your treatments your way in the end, right? We want you to know that you did it the way you wanted to do it. That being said, you know, like I said earlier, the blood cancers do well with the leukemias and lymphomas with dose dense. But like I said, we will do fractionated chemo if the patient's adamant about it, if they got really sick from doing the conventional treatment. I had a couple of patients who were adamant about starting fractionated chemo, and I'm like, okay, we'll do it, you know, and they did well. Every patient case is different and unique.
It is. And that's why all the testing, the more individualized testing, that we can get individualized answers and then make an individualized protocol.
Yeah.
I think that's critical. I think individualized medicine sounds I guess remedial, but that's the future of medicine. The individualized approach has to be, because we're all different. Same cancer, same diagnosis, same everything, could be two entirely different approaches. Some of the main things, maybe, but there's a lot of different things that could be applied to make sure that the outcome's the best we can get it. So.
Correct. All right. What other therapies are best when combined with low-dose chemo, like immunotherapies, repurposed drugs, etc.? There's many theories, right? Used in combination with fractionated chemo with the biological response modifier that works synergistically, like Dr. Roney was stipulating earlier, for the kill phase of the cancer, such as the immunotherapies, which we garner from the NGS, the next generation sequencing testing and studies from Guardant, Fulgent, Caris. These are just a few to name. Dietary, RGCC, it targets the patient's specific biomarkers and their gene mutations. It helps us decide, if we want to consider an immunotherapy instead of chemotherapy. That's also another option, which, if it's a PD-L1, we like to put them on Keytruda. It's been shown to keep people, in NED, just that alone. So it's pretty amazing right now with all the testing that's out there.
We can get much more individualized as far as what treatment might work best for you, right?
And give you more options, basically, right?
Right, exactly.
Repurposed medications, I always give credit to Jay McClellan, like I said earlier, who I was fortunate to meet at a conference last week. I wasn't.
Oh, no way.
I didn't know she was going to be there. She's a beautiful, beautiful woman. Who first came up with this method, I think, and wrote the book, How to Starve Cancer. I tell everybody to read it. I read it, and I'm like, I want to be your best friend. I didn't tell her that when I met her, but I did.
Sure. You're stalking her.
Yeah, exactly. I was. Sorry, Jane. With repurposed medicines, we're always racing against time from generating heterogeneous cancer cells that are going to develop resistance if we give them enough time. So we want to put the hammer on it, like we said. We want to cut it off at the pass, right? If we can shut down the tumor promoters and support the tumor suppressors, that is what we want to do with the natural products and with the repurposed medications that help us to do just that. And like that earlier question about what's the cheapest way, that's really the cheapest way to do it, and it works. So get her book. Also
stimulates cytotoxic effects. So just using vitamin C, a lot of you may know this, but the vitamin C, cancer cells lack an enzyme called catalase. So what happens when you have high doses of vitamin C, the cancer cells convert it to hydrogen peroxide, whereas normal healthy cells convert it to very usable forms, right? So the hydrogen peroxide becomes what they call cytotoxic. So it can actually help kill or damage cancer cells. Now again, sometimes is that a bullet, a BB? Is it enough to hold? That's a caveat to this. Same with hyperthermia. So we can combine low dose chemo, like we talked about earlier, with hyperthermia that Trish explained, with vitamin C IV, with some of these modalities that have been really studied heavily to create the cytotoxic effect. And now, again, you're hitting it with a bullet, a BB, a cannonball, a grenade, and a bomb.
Yeah.
That to me just makes
it resonates.
It resonates, exactly right. So hopefully that answers the question that there are a lot of things that could be done. And then there's supplements that really help, break down the wall of the cancer cell, your pancreatic enzymes. Right. And there's a lot of evidence to support that. And then making sure your immune system with the supplements are boosted and making sure. So again, you start layering a lot of these strategies. Again, I know I'm redundant, but that's where the winning comes in. True. But that's the idea.
Yeah.
Okay.
Next question is there
any blood? Trish mentioned any blood type of cancer typically does better, and actually it's pretty effective. Yeah. Quite honestly. So if there's if the percentages are good in a certain area, we typically go with those percentages. So why, and then again, to your point, if they're adamant, we'll definitely work on it. And then anything can be changed at any time. Right. The pivoting within seconds. Exactly. Honestly, with data. So I always tell people, if you're not 100% sure of the route, you can do the route, and then we just survey it, consistently. And then we can change the route at any time. Right. So.
Then someone had a question about diet. Majority of the time we put our patients on the keto diet because this is a metabolic disease. It loves sugar, like Dr. Roney was explaining earlier.
Dr.
Seyfried's work. And that's really what we find most successful for our patients, is just killing off another pathway with the glucose and the glutamine, like you said. My patients that come in for fractionated chemo, we like them coming in fasting, like 12 to 13 hour intermittent fast, with hydration. The goal is always half your body weight in ounces. I also hydrate my patients before they get their chemo, so that helps. We want people to eliminate processed packaged foods. Foods should be organic, decrease simple carbohydrates when and where possible. We want people to increase their fiber and their veggies, their protein. Protein goal is usually a minimum of 25 grams of protein per meal daily, particularly if they are receiving chemotherapy, to heal the tissues and to maintain their weight, because it's really important. A lot of my patients, have issues with too much weight loss.
Absolutely.
So we really gotta be on it,
It's the bone, it's the building. It's called anabolic versus catabolic. So you need the nutrients for sure.
Yeah, for the muscle mass also. So we like you to consume your fiber before your protein and fats before your carbs every meal for a more balanced blood sugar. And people do really well on it. We'll sometimes, if people are having issues, we'll do a revised kind of Mediterranean modified or a paleo, something similar. But really, it's staying away from the glucose.
Yeah, I agree. Your keto, like Siegfried's work, talks about using the Keto Mojo, getting your GK index below 2. That's his research. He was adamant. He said, if we can get it below 1, great. But I don't know if you've ever done keto. That's hard.
Yeah.
So there's a lot to that. What I would suggest if you're going that direction is definitely get with a nutritionist. I know Liliana's really good at it here, because they can dial in your macros. How many grams for this, grams for that, etc. And then it can help avoid, if you're doing the ketogenic diet and pushing it that hard, it prevents weight loss too, because you need the calories. And a lot of people, it's hard. It's not, like, if I do it, I always lose weight, and I don't want to, and it's the one thing I don't want to do is lose weight, but I do feel really good on it. And it's hard for me to dial in eating enough calories to offset it. So that's something that we have to individualize, right? If we see somebody that's very petite and small, I'm not sure the ketogenic diet is the best, right? So we have to make adjustments. Individualized care. And then to your point, the next best thing is going to be, I use the whole paleo mindset, or hunter and gatherer. If you're on an island, what could you eat? You could pick it or chase it. Now I know that gets into meats, which again, I understand the research. I get it. So I'm not opposed to either one, to be honest with you. If you were doing meats, you're pasture raised, pasture finished, very clean, and then maybe utilizing them, moderately, if that. And then you work in your plant-based proteins, your good fats, and keeping your carbs very clean, very organic, but very controlled. Right. And I think real food, so I like to say, if you can't go do the keto, if you're eating real food and you're keeping the macros, a nice percentage of, your fats and proteins, and keeping your carbs under control, I think that's not a bad next step. Would you agree? I do. Yeah. Clean. Yeah. The best I could say is clean. And I think most of our patients know, they come in with that working knowledge now that, farm to table is another way that I'll express it. So I definitely know the whole plant-based versus meat. I totally get it. And I think there's a place a little bit sometimes for both. Sure. Because of the muscle building and the cachexia, the cachexia patients that we see. Right. We just see them do this. And sometimes I think the diet that they're on is, there's a saying, you don't want to throw the baby out with the bathwater. And so we have to be cautious and individualistic, I think, on that one. So is that it? That's all I have. All right, gang. So I know there's a lot of Q&A still in the queue there. What we'll do is we'll make sure we either carry them over to the next time, or we'll try to answer some of the ones throughout the next week or two. So I just wanted to let you know we're not going to leave you hanging. We always try to answer them. We know they're important. We appreciate you coming on. We appreciate you sending in your questions. But honestly, we usually would be here all night. I know. So we want to make sure that we don't hold you too long. And then, we get Trish home and she can get some rest and R&R. and then I have to do my little bit of workout and eat too. So we'll let everybody kind of go. So what I want to just do, I do this every time, just give you an idea. If you had any questions or concerns, Vicki at the healing side is 949-581-4673. And that is inquiries. If you have questions or concerns, if you need some help, I can always jump in, gang, and do a consult and answer some of your specific questions. Not necessarily giving you specific advice, but if you're like, hey, I may want to come, or what can I do about this, or a plan, I can always help, and Vicki can help set that up. So I'm happy to do that. I love just sharing the message, regardless. Regardless. Let me just say that. The center side, if you're looking for the wellness part of it, and Sydney has me do this because I think she puts up the information right here. I'm learning. So 949-680-1880, and that's Miles. Miles does a really good job of processing. If you, he understands if you wanted prevention, he knows exactly what to push you towards as far as the testing, the follow-ups, etc. So we have that cadence down well as well. So prevention, I keep saying it, 2024 is a big year for us pushing the preventative part because of what we're seeing.
Yes.
It's just, any practitioner here will tell you it's younger and younger. Mm-hmm. Cancers that Keneally would say had a 50-year warranty, 60-year warranty, we're seeing them, early 20s, early 30s. So it's, I think it's just important, period. Even from a learning standpoint, to learn that wellness concept. So anyway, thank you for being here, Trish.
Thank you so much.
Great job. Yeah. Any questions, concerns, please reach out. We're always here to help, and thank you for being here. Okay?
All right.
Hey, much love, everybody.
You.